Epiphyseal plate fractures, what they are and why you don't want one. Okay, so what is an epiphyseal plate fracture? Epiphyseal is just another word for growth plates. So growth plates are the areas of cartilage located near the ends of bones. They are only found in long bones, not like sesamoid or flat bones. Each long bone has at least 2 growth plates, one at each end, and the growth plate itself is located between the metaphysis and epiphysis. Growth occurs at each end of the bone around the growth plates, and growth plates are the weakest area of a child's growing skeleton. And this is because growth plates are the last part of the bone to ossify, so when a child is fully grown, the growth plate hardens into solid bone. However, because the growth plate is the last part of the bone to ossify, growth plates are especially susceptible to fracture. There are 5 different types of epiphyseal plate fractures. Type 1 is a break through the bone at the growth plate, separating the bone end from the bone shaft and completely disrupting the growth plate. Type 2 is like an extension of type 1. It's similar in that it is a break through the bone at the growth plate. However, with type 2, the crack goes through the bone shaft as well, and this is the most common type of growth plate fracture. Type 3, the fracture crosses through a portion of the growth plate and breaks off a piece of the bone end, and this is more common in older children. Type 4 is a break through the bone shaft, the growth plate, and the end of the bone. And type 5 is a crushing injury to the growth plate from a compression force, and these type 5 are very rare. Who is most susceptible to this fracture? Because the growth plate is the weakest point of a child's growing skeleton, injuries frequently do happen in children and adolescents. An injury that would cause a sprain in an adult is more likely to cause a bone fracture in a child, just because a child's bone is much more fragile than an adult's, and as many as 1/3 of all childhood fractures are growth plate injuries. And growth plate injuries are twice as likely to occur in boys than girls, and one of the reasons for this is because girls' bodies mature earlier than boys' bodies, so their growth plates are replaced by stronger bone at an earlier age than boys' bones would be. How do growth plate fractures occur? Growth plate fractures most often occur, as stated before, in long bones of the body as opposed to like sesamoid or flat bones, the most common ones being femur, tibia, and fibula, radius, sometimes ankle or foot bones, and phalanges. And most growth plate injuries in children result from a fall, usually while running or playing competitive sports such as football, basketball, baseball, softball, track, and gymnastics. And also in competitive sports, a lot of the repetitive movements in sports like gymnastics or baseball can cause growth plate injuries too, just from the constant pounding on the bones. And then also recreational activities such as biking, sledding, skiing, skateboarding, and rollerblading. Okay, now that you know how you get this fracture, how do you recognize it? First, there will be persistent pain that will not diminish after a few days, and it may get worse if this condition goes undiagnosed. There may be an inability to move the joint due to pain, and it's often occurring in youth, as Ellery mentioned. Something to note here is that this injury is not always as obvious as a fracture, so it's important to keep the possibility of an epiphyseal plate fracture in mind if a skeletally immature patient is presenting with these symptoms. There may be presence of an antalgic gait. This is limping, and it's only if the injury is to the lower limb, obviously. There may be possible limb length differences, and there may be a presence of a visible deformity. Long-term consequences. There may be chronic pain over the fracture site after healing. Osteoarthritis is not uncommon later in life because these fractures are occurring typically along joint lines and can impact the structural integrity of the cartilage. Uneven limbs can occur because of an overstimulation of healing by the limb. There will be increased osteoblastic recruitment activity to the fracture site, causing it to essentially overheal
When this happens, the injured limb is consequently longer than the uninjured limb. If the fracture is occurring at the knee, it's not uncommon for the patient to have follow-up visits until they are skeletally mature, but if it occurs elsewhere, it's standard for the patient to have follow-up visits for up to a year after the injury. As mentioned on the last slide, uneven limbs can occur. Here you can see if a child's knee is fractured at the epiphyseal plate, it will heal as if it were a fracture on any other part of the bone. The site that was the fracture and was formerly a gap formed by the growth plate will now be filled with a bony bridge. If this occurs on one side of the bone, then you will end up with a closed growth plate on that side and limited growth, while the other side continues to lengthen and mature. This can cause abnormalities in bone length and overall limb structure, which can result in some of the conditions mentioned in the previous slide. Okay, on to intervention strategies. There is the non-surgical side, which, if this fracture is treated properly and caught in time, many can heal properly without surgery by simply applying a stabilizing cast and limiting participation in physical activity. Sometimes, however, surgical interventions are required if this fracture is unstable. The image on the right is of the reduction in internal fixation surgery, which is the most commonly used surgery to fix these fractures. As you can see, the bone fragment has been reduced, or moved back into place, and fixed there by screws, hence the name. However, it's not uncommon for the surgeon to splint this post-surgery. Well, how does this fracture heal? Initially, the inflammatory response recruits mesenchymal cells that will differentiate into bone and cartilage-producing cells. A cartilaginous soft callus is then formed by chondroblasts. Eventually, the cartilaginous callus will be removed by osteocytes and then replaced by bone via osteoblastic activity that I previously mentioned. Osteoblasts will form the hard callus and continue to lay a bony matrix around the fracture throughout the patient's life. Eventually, all of the weaker spongy bone from the bony callus will be replaced by healthy new bone. This can be demonstrated in the picture below.